some sort of mental health diagnosis along with this. I know pain brings a lot of depression and things like that. If you proactively treat a comorbid psychiatric diagnosis that you're aware of, is there more success in preventing addiction in the first place? If you do have no other option but, say, to prescribe, highly addictive drugs.
I think relatively few people would proactively treat a disorder on the chance that it might occur. But I think what is lacking in pain management, from my point of view, is being aggressive about treating what is there. And the one thing I would agree with several other panelists about is that, and there are actually very good data on this, is that undertreatment of mental health problems is a major risk factor for relapse. So if you have a depressed person who is substance dependent, you dry them out, and you don't fix the mood disorder, you're really asking for a relapse. It's like doubles the chance of relapse. So I don't know about treating it like you suggested proactive. I think it's a great idea, but
I don't mean like you're saying you're going to be depressed, so here's, antidepressants. It's not in a drug sense at all, but just being, I guess it's more education, just being aware this is likely to either already coexist or lead to something.
It often, because at least from the patients I see, it coexists, and because the other practitioners who are maybe treating the pain management docs are often not as sensitive to screening, not as sensitive to assessing it, and certainly not very good about treating it.
And what about these drugs causing depression themselves as an issue?
What about what does?
These drugs causing depression itself that maybe wasn't there before.
Well, that's a long-standing issue about whether drug abuse causes depression or depression is simply medicated by folks. The data are, that people argue both sides of it. There was actually just a recent pretty good study in a psychiatric journal that suggested that heavy drinking precedes depression and not vice versa. I think that the actual answer is unfortunately not a simple statement that one thing causes another. I think the same things that go into alcoholism and drug abuse are also often intimately related to pain. That one person may have a similar physical injury and not have much disability or depression from it, but other people do. So I think it's a complicated interaction of genetics, psychological stressors, and social status.
And age of initiation of substance abuse.
Yeah, that's actually, there's actually very interesting data. For example, we look at interaction of things like exposure to substances at different genotypes, which I think is probably what you were talking about way back toward the beginning, that exposure at a certain time may sensitize folks, make it more likely that they develop a long-term problem.
Dr. Ken Blum, who's a geneticist who found the addiction gene, the D2 receptor site, one of the things that phrases that he coined was reward deficiency syndrome. They don't have enough dopamine a lot of times, and sometimes you can stimulate that with different things, and then all of a sudden now they got this easy pill to take and stuff like that, and they're off to the races.
And then additionally, chronic pain pathways are mediated by some of the same biochemicals as depressants or mood pathways. So a lot of chronic pain patients will ultimately develop depression with or without anxiety, just if nothing else, just because of the fact that their lives have been altered by the pain. And in my practice, a lot of those patients will get put on either antidepressants of some sort, either SSRIs, SNRIs. Tricyclics have been around for the use of chronic pain for a long time, and actually has been a mainstay of fibromyalgia therapy. And now we look at the new medications for fibromyalgia. Two of them are serotonin norepinephrine reuptake inhibitors. So they're working on biochemical pathways that affect both pain as well as mood.
I think also outside of medicating or using pharmacological interventions, you've got like an entire field of occupational therapy that's designed, to work with people who, you just hurt your back, now you can't go out, you can't go to work, you can't care for your family, you can't do all those things that you associate with daily life and living. I mean, clearly you're going to have some issues that go along with that, and inside of this, the multidisciplinary approach that the law is going to be suggesting, I think we need to look at other practitioners as well and bring them into the mix.
That's what I was going to say too, is I think one of the answers to that is the multidisciplinary approach where you treat the body and the mind, both.
Okay, thank you.
Well, I think we should say thank you to our panel here of experts. Thank you for letting us pick your brain tonight, or multiple brains. I think that, clearly there are no easy answers to this problem, but I think asking questions is step one. And again, I just am personally quite impressed with the fact that you young doctors, you doctors of the future, are here and you care about this. I think that's just wonderful. Thank you for allowing me to participate with you tonight, and best of luck to all of you.